Yes, sir.
You see me zoom in?
Yes.
Okay. All right. Spot diagnosis here now. What sort of study is this? What sort of image is this? It's a CT scan. So looking at transverse cuts. So we're looking at skin. We're looking at vertebra. We're looking at ribs. We're looking at anterior abdominal wall. Anterior abdominal wall here. We're looking at, so what's this structure sitting right in front of the vertebral column? Showing up bright white.
Aorta.
Yeah, that's the abdominal aorta, that's right. So this is a contrast film. So what do we see on this abdominal CT film, upper abdominal contrast film? That's right, metastatic bilobar liver disease, multiple nodules, quite likely metastatic disease. What are the likely sources? Pancreatic CA, gastric CA, breast CA,
From the lung as well.
lung CA, possibly. Anything else?
I believe thyroid as well.
Possibly. The thyroid behaves very nicely, you know, but the day you see multiple liver mets from thyroid, is boy, we just call you salt, you know what I mean? But that multiple metastatic hepatic bilobar metastases. I just need to give us a few examples: colonic CA, gastric CA, GI tract malignancies, breast malignancies, prostate malignancies. Should I give you guys this one? Yeah, man, I'll give you guys this one. What are we looking at here?
Sorry, Doc, before you move on, what you said was the white thing in front of the vertebra, because I had chipped out a little bit.
Abdominal aorta.
Okay, thanks.
A contrast film. Remember, you get IV contrast, you get oral contrast. But this IV contrast shows up the blood vessels. It's showing up vessels going into which structure is this over here? Any ideas? Yeah, big fat spleen right here, and you see the splenic vessels. So what would this be right here? Yeah, that's the stomach. Yeah, I see you guys have this thing done, man. I can't stop right here, man. You guys are good. All right. All right. Let's try this one. This is a little bit more tricky. Well, maybe not. What sort of a study is this? Yeah, it's a bear on me. Why do you say that? Well, it's further down, you know, this is a pelvis, you know. Yeah, so is it lucky or you thought this one through? Yeah, but why would the stomach be hanging all the way down in the pelvis like this? What do you see? It is a burial meal. You see in the contrast coming, and it's just sitting in the stomach here, and that stomach is hanging all the way down into the pelvis like an apron. But what's happening here or what's not happening here? Why is the stomach hanging down like this, and you notice the contrast stops here? Eh? What's happening, you think? Anybody?
Pyloric stenosis.
Yeah, gastric outlet is obstructed from pyloric stenosis of some reason, either from peptic ulcer disease or malignancy. But the stomach over days, weeks, months, and years are just gradually gotten larger and larger until it's hanging down into the pelvis like an apron. And this is fluid filled, debris and all of that. What sort of electrolyte imbalance you think you would get from a patient like this? Well, even before that, how would a patient like this present? What would they complain of? Yeah, projectile vomiting, non-bilious vomiting, partially digested food. So that have been happening over years. So they will be wasted, emaciated, because they've been significantly malnourished over a long period of time. So what sort of electrolyte imbalance do you think these patients would present with? Okay, but give me the basic ones before you get into them high-tech stuff. Sort of electrolyte imbalance you've had from these days, weeks, months of vomiting. Low hypokalemic, hypochloremic, hyponatremic, metabolic what? Alkalosis. Because they've been losing all of that acid in the vomit as well. Potassium levels would be low, the sodium levels would be low, the chloride levels would be low, hydrogen ion levels would be also low. So the hypochloremic, hyponatremic, hypokalemic, metabolic alkalosis. Metabolic alkalosis. It's another talk all on its own. Easy one here. Somebody tell me what the diagnosis is without batting an eye. An AP film, because you see in the scapula and the lung field. What's the diagnosis? What's the diagnosis?
If it's due traumatic cause, a pneumothorax.
That's right. You see in the blood here. How much blood is this?
Definitely more than a liter.
Definitely more than a liter. We're looking at 3-4 liters right here. And you can see the lung mark in here. You see that?
Yes, sir.
This is your scapula. This is your lung. So that's a pneumothorax. Anybody want to hazard a guess on this film? What sort of a study is this? Come on, guys. What imaging modality is this? Come on, don't think too hard. Yeah? Yeah, it's an abdominal, supine abdominal film. Showing what? That's right. Where's the obstruction? Proximal descending. So because you see in the colon here and then it disappears right here. That is splenic flexure. But what sort of obstruction is this that would have me particularly concerned? What are we not seeing on this film? Okay, so it's obstructed right here. So it's blocked right here. But if it's blocked right here, so the pressure is backed up here, right? So what would we have expected to see? Yeah. Okay, so you have an obstruction at the level of the splenic flexure. So you have back pressure. So where would this pressure back up to? Are you seeing any small intestines here? So where's the pressure backed up to? So what type of an obstruction is this? So we're blocked here, but there's nothing backing up and going into the small intestine. So it's also blocked here. What do we call this? Yeah, we call this a closed loop obstruction. So you're blocked here. But the good thing in many instances is that pressure is offloaded into the small intestine, so the small intestines eventually dilates. But if the ileocecal valve is holding, that pressure is going to build up pretty rapidly in the cecum. And what do you think is likely to happen rather quickly? Ventral perforation. So we see this on X-ray. This patient has a blind loop obstruction with imminent cecal perforation. But normally you just see loops and loops of small intestines, but that's not happening. They're blocked here, they're blocked here. This is a closed loop obstruction. The ileocecal valve is competent, so it will not allow flow back into the terminal ileum. In most instances, the ileocecal valve will become incompetent, which is a good thing. It buys you time. Spot diagnosis. Primary. Possible breast. Here we're looking at a big fat nodule, right? Lump here. That's quite likely a breast nodule. If it's a male patient, it's a lung primary with lung mets, but it's quite likely this is the origin of breast malignancy with bilobar lung metastatic disease, by so-called coin lesions. Spot diagnosis. Where? It's a closed loop, but what's its classical sign called? I don't want to give you guys too much information in one night, and you're gonna get a headache when you go to bed now, you know. I was going to have a couple more slides and then we call it off. It's too much.
Sausage-shaped obstruction.
Huh?
It's a sausage-shaped sign. So in
Well, I never really hear about the sausage one still, but come again. Eh? What's this one? It's an omega sign. Characteristic of a sigmoid volvulus. The sigmoid is twisted right here, and then all of the, so what you're looking at here is all sigmoid colon. It's an omega sign. Enlarges up to the right upper quadrant. Sigmoid volvulus. And this, of course, is what you will get in every exam. What are we looking at here? Small bowel obstruction. How do you know? The presence of plicae. So the folds, mucosal folds go right across. And what's the second feature of small bowel obstruction? Not that. This is a supine film. There's plicae and its location, which is central. Central location. So this is a classical film. Plicae, centrality, small bowel obstruction. The top three causes for small bowel obstruction. 1, in any given order. 1, adhesions. 2, 3, malignancies. That's right. Done that. Spot diagnosis. Chronic venous ulcer, medial malleolus, ankle swelling, surrounding hyperpigmentation. Hyperpigmentation doesn't involve the foot, which you get with peripheral artery disease, but it's a venous ulcer. Venous ulcer. What investigation is required for all of these patients with venous ulcers? Venous Doppler ultrasound, looking at which valves are incompetent. Okay. One sec.